So just give a little overview, mostly for the men in the audience who might not be so savvy. So a typical menstrual cycle lasts perhaps every 28 to 30 days and has two components, the follicular phase and the luteal phase, and they're separated by the time of ovulation, which is about right here in the middle, and this ovulation occurs over about 24 hours. And this is the time when women are fertile, right in the middle of the month. So if you're going to try to become fertile, this is when you have to have sexual intercourse. So the luteal phase is characterized by the production of progesterone by the corpus luteum, which is the change in the morphology and gene expression of the granulosa cells, which occurs at this time. During the follicular phase, there are lots of follicles and ovum which are recruited and start to grow, but only one is selected and ovulates, and the rest undergo what's called atresia. So if a typical woman's reproductive life is 40 years and 12 months for a year, maybe around 500 ovum, and you start out with 1 million, you can see that the vast majority of the eggs go through atresia, and why one is selected for growth and dominance and ovulation is unclear. So the levels of estradiol change during the cycle, so they rise to a level of about 300 picograms per mil, and that's one of the factors which triggers the LH surge. You can see the progesterone level goes up only in the luteal phase and is quite low in the follicular phase. So if you measure the progesterone and during the luteal phase, you can show that the woman is ovulating. So to understand how we evaluate people for reproductive problems beginning in young adults, you have to remind yourself about the milestones of pubertal development. And here we have girls above and boys below. And for girls, the first event in pubertal development is breast budding, which typically takes place about 10.5 years, but can be as early as 8 years nowadays. And soon after the breast budding, you get pubic hair growth. And soon after that, girls have their peak height velocity at about age 12. And menses begin just before age 13 with a range of about 10 to 16 and a half. Boys start their sexual development with growth of the testis, not very different from the time of breast development. But in boys, the other events are more delayed. So pubic hair growth doesn't occur until after age 12. And the peak height velocity, it doesn't occur until age 14 or 15. So in a young lady, we talk about primary and secondary amenorrhea. Primary means that menarche, menses, don't begin at all but until age, if not at all, by age 15 or 16, if there's no breast development. But if the breast development occurs, I showed you that you expect the menses to occur soon thereafter. So if there's any breast development and no menses within 5 months, that usually indicates that something's amiss. And if there's no breast development at all by age 13, that's also way beyond the standard deviations, and that's warrants medical evaluation. Secondary amenorrhea is the term used for amenorrhea, which occurs after the menses have been established regularly for about 6 months. So to decide how to work up patients who have gonadal problems, you have to remember your basic physiology of feed-forward and feedback regulation, which applies to almost all the endocrine glands. So the proximate regulator of the reproductive system are GnRH neurons, and they send their axons down into the median eminence, and they stimulate the synthesis and secretion of the gonadotropins, which activate the ovary and the testis, and then negative feedback from sex steroids affects both the pituitary gland and the hypothalamus. A new player on the block in the last decade is neurons that express kisspeptin, and these neurons are the major site of the steroid negative feedback, and seem to be the site where the GnRH gets its signals. So if the ovary is damaged, these negative feedback signals don't occur, and the levels of GnRH and LH rise. You can't really measure GnRH in the blood. It's only found in the hypothalamic portal blood. On the other hand, if the ovary is not working correctly, and you're not having ovulation, and the gonadotropins are not elevated, then you know that the problem has to be from above. So, I know that you like to answer questions. So, we have a 17-year-old girl who consults you because of primary amenorrhea. She's otherwise healthy. On physical exam, she's 5 foot tall, and she weighs 112 pounds. Her blood pressure is normal. She has a large number of freckles. The breasts are underdeveloped, and there's very little pubic hair. Pelvic exam reveals the cervix and the uterus, and the level of FSH is high, 40, and LH is also high, 32. Which of the following tests should provide insight into her diagnosis? TSH, MRI of the pituitary, peripheral blood karyotype, serum testosterone, and insulin tolerance test. Yeah, that's exactly right. Peripheral blood karyotype. And I was trying to present to you a young lady with Turner syndrome. And here's a typical appearance of a Turner's patient with a webbed neck and large low-set ears and anti-slanted eyes and a fish-shaped mouth and underdeveloped breasts with sort of a shield-like chest. Typical Turner's patient. And these patients, of course, have lost one of their chromosomes, so the majority of them have a 45X chromosomal constitution. But there are others, nearly half, who have a variety of karyotypic abnormalities, either mosaicism, so 46XX, 45X, or they have something called isochromosomes, where you have 2 short arms or 2 long arms, or you can have deletions and deletions which join up, called rings. So all of these are various types of karyotypic abnormalities which you might encounter in a young lady with primary gonadal failure. So because of the genes that are missing, they have skeletal growth disturbances. They're short. They have short extremities, cubital valgus, and scoliosis, genuvalgum, small jaw, high arch palate, otitis media. And of course, because the extra X, you're missing all those genes to activate the genes in the ovary. They have a streaked gonad, causing gonadal failure and, of course, infertility. And they get lymphatic obstruction. They get other abnormalities in the kidney and in the heart. And one recently identified issue for Turner's patients is the propensity for obesity, a third of the patients here, and the propensity for them to have NAFLD. The age-adjusted mortality in Turner syndrome is about threefold above normal. And the particular issues relate to congenital abnormalities, especially in the heart, with aortic valve disease, bicuspid valve, or coarctation of the aorta, and the development of aortic aneurysms are far, far, far more common and are the major factors leading to increased death rate among Turner's patients. In fact, the congenital heart disease, such as hypoplastic heart and hypoplastic aortas, are the reason why most babies who are Turner syndrome die during fetal life, and only a small portion really make it to birth. So primary amenorrhea, about 50% of the cases are due to ovarian failure, high LH and FSH, get a karyotype. Other patients may have hypothalamic pituitary problems. Some will have secondary disorders, psychological, nutritional, and systemic illnesses. Occasionally you have congenital absence of the uterus. And now we're seeing more and more patients with PCOS, formerly a cause of secondary amenorrhea, expressing itself younger and younger in girls such that they have primary amenorrhea. So one other form of gonadal failure I wanted to highlight for you is called autoimmune polyglandular endocrine failure, and there are two forms, type 1 and type 2. The type 1 is uncommon, but it's a nice board exam because you see patients with mucocutaneous candidiasis of the lips, fingers, etc., who then, as young children and teenagers, develop Addison's disease, hypothyroidism, hypoparathyroidism, and ovarian failure. And these patients have been found to have this autoimmune regulator gene mutation, APS1, and it's of great interest to immunologists because it helps them understand how the immune system controls genes in endocrine glands. The types 2 and 3 are much more common. We used to call them Schmidt syndrome. You might have been familiar with that. And this is the association of Addison's disease and Hashimoto's thyroiditis. Some patients have diabetes, pernicious anemia, and vitiligo is very common, even beginning in childhood, and sometimes you'll see ovarian failure. So if the gonadotropins in our patient were low and not high, and she had very little sexual development, then a karyotype wouldn't have been helpful. Instead, start to think of other types of differential, and usually it's divided into genetic causes and acquired causes. And the genetic causes of hypogonadotropic hypogonadism in males and females relate to the deficiency in GnRH, the development of the pituitary gland, which sometimes can occur together with other abnormalities of the pituitary, such that the patients are quite short and have growth hormone deficiency and hypogonadotropic hypogonadism. And remember that you can get all sorts of tumors, cell and supracellular region, infiltrative diseases. We took care of a patient in the past year with sarcoidosis who had hypogonadism. You can have it after head trauma and radiation. There are occasional unusual syndromes in which hypogonadism is seen, and also what's called functional hypogonadotropic hypogonadism due to excessive thinness, often with exercise or with stress. Okay, so here is a 27-year-old woman who has had oligomenorrhea and hirsutism since age 13 and has had no menses in the past year. She is not currently interested in pregnancy but would like to have children in the future. Her primary concern is her hirsutism. Her height is 165 centimeters. Her weight is 79 kilos with a BMI of 29.5. And there's modest hirsutism in the face and lower abdomen. And she has acanthosis nigricans in the back of her neck. There's no galactorrhea. Her testosterone level is slightly elevated. Her SHBG is low, so that the free testosterone is even higher. So which of the following is not appropriate therapy at this time? Okay, which is not? Clomiphene citrate, metformin, lifestyle changes, oral contraceptives, and spironolactone. Now you're right. So clomiphene citrate is a SERM. It's an anti-estrogen, so it blocks negative feedback by estrogens, increases the gonadotropins, and is a drug used to stimulate ovulation in women who have anovulation. And it wouldn't be appropriate at this time. All the others certainly would be. Metformin to improve the insulin resistance, lifestyle changes, she needs to lose weight, and the standard fare treatment that we heard from Dr. Denafe not too long ago is to suppress the gonadotropins with oral contraceptives and to use the anti-androgen spironolactone to block. Very good. You got that one. So among the two major causes of secondary amenorrhea nowadays are PCOS and functional hypothalamic amenorrhea, which includes weight loss and exercise-related amenorrhea. The other possible ones include hyperprolactinemia, hypogonadotropic hypogonadism, for example, head injuries, pituitary tumors, etc., and women who have premature ovarian failure. So PCOS patients have three things: an ovulatory dysfunction, too much male hormones, and polycystic ovaries when you do an ultrasound. And there are people who argue about all of these different ones. How many do you need? Which ones are right? Blah, blah, blah. Because not every patient has everything. And really, PCOS is still a syndrome. The etiology and pathogenesis isn't clear. So we have to define it based on some sort of clinical attributes. And these are the three things to look for. The anovulation could be amenorrhea. It could be irregular menses, or even women who have apparently regular menses but are infertile. The hyperandrogenism is often hirsutism, acne, a male pattern baldness, but all of these are multigenic, and you'll find some patients with high androgens who don't have any of those things. And of course, the polycystic ovaries are nonspecific. That's why some of the non-gynecologists don't favor including this, but it's certainly often part of the syndrome. So patients who have PCOS tend to be overweight. These are the sisters as controls. They often have an increased waist to hip ratio. They have elevated testosterone levels, but not very high into the normal range, just mildly elevated. They have low sex hormone binding globulin levels, and therefore the free testosterone is even higher than the total testosterone. The DHEAS, an androgenic-like steroid that comes from the adrenals, is also increased, and why that occurs is part of the puzzle. And the androstenedione, which comes from both, is a little bit high, and the patients usually have a normal cortisol levels. One of the things about taking a history in PCOS is that it's probably a genetic disease, and it usually is expressed first in adolescence. So here are a group of girls who are 15 years old, some of whom have irregular periods and some don't. And you can see that among the ones with the irregular periods, the LH levels tend to be higher, the testosterone levels tend to be higher. So these are some of the first early manifestations of PCOS in the adolescent group. Often they're heavier than their controls. That wasn't the case here. So the LH levels are high because the GnRH pulse generator is producing GnRH too often. These are levels of LH in a normal woman here over the course of 24 hours. And you can see the secretory episodes. And you can see that the level of LH is much higher in the PCOS patient, and that the frequency of those bursts is much more frequent. So why this occurs? Some people think it has to do with too much androgens. Others are not sure at all. So the common thoughts about PCOS now is you're making too much LH, but you're also insulin resistant. And between the insulin and the LH, insulin resistance of the LH, it causes the ovary to make too much androgens, and somehow the adrenal is also making that DHEAS. So Dr. Dene visited with us a few weeks ago, and this was one of the seminal contributions to the literature that she made some years ago now to highlight the fact that patients with PCOS are insulin resistant. And of course, those who are overweight, it's not surprising, but if you look at overweight PCOS patients versus overweight patients who are not PCOS, you can already see differences. And of course, there are lean PCOS patients who shouldn't be insulin resistant at all. So here are the lean patients. You can see that as young adults, they have normal glucose levels. But you can see that when you do a glucose tolerance test, but not a fasting insulin, the glucose tolerance test causes them to have hyperinsulinemia, and therefore you can identify hyperinsulinemia and therefore identify the PCOS syndrome in part by doing a glucose tolerance test. In the patients with PCOS who are overweight, they already begin to have some hyperglycemia, but it's certainly not in the diabetic range in young adulthood. And you can see that often the fasting basal insulin levels elevated, and of course this is amplified and exaggerated by the glucose tolerance test. So as you follow PCOS patients when they get older, there's more and more of a chance of developing diabetes, and This is a somewhat old paper, so I don't really know what the statistics are now. And you can see that many will have impaired glucose tolerance test, and that'll get more common also as the women get older. It's also been highlighted that there are many non-reproductive consequences of PCOS, such that the internist is going to play a role and does play a role in the clinical care of PCOS patients. Of course, the obesity, insulin resistance, and type 2 diabetes that we talked about, the tendency to have dyslipidemia and NAFLD, do those things translate into an increased cardiovascular disease likelihood? This is a controversy still. Patients with PCOS are more likely to have hypertension, more likely to be depressed, and have a high prevalence of sleep apnea. So all of these things are non-reproductive consequences that you have to think about in your internal medicine care of PCOS patients. So not all patients who have hirsutism have PCOS, and you have to then think initially, do the patients have virilization? So virilization is generally an enlargement of the clitoris. It's often a decrease in the voice pitch and male pattern balding, lots of balding. And if you see those things, then you want to be very attentive to the sex steroid levels. If the testosterone level is very high, more than 200 nanograms per deciliter, or the DHEAS is very high, more than twice the normal range, think about ovarian or adrenal tumors rather than PCOS. And in the patients without virilization, you have to think about non-classic congenital adrenal hyperplasia, Cushing syndrome, and acromegaly. All of those can be easily confused with PCOS. So look for a disorder that begins in adolescence. Find out if there's a family history of diabetes. Look for the acanthosis nigricans, and don't come to the default diagnosis of PCOS, but think about these other things as well. So on the other end of the spectrum of nutrition and reproduction is weight loss. So patients with weight loss in the extreme sometimes have what's known as anorexia nervosa, which is a psychiatric disorder, which in young individuals will result in delay in puberty, and in older girls and young adult women will result in secondary amenorrhea as well as primary amenorrhea. With the weight loss, you frequently have low T3, just like you do in anyone with non-thyroidal illness. They're under stress. They make cortisol excess. The IGF-1 goes down. They have a tendency to hypoglycemia, hypokalemia, hypophosphatemia, and low bone mass. So there are lots of endocrine parameters which are thought to play a role in the endocrine dysfunction and anorexia. Of course, the basic reason for anorexia is not known. But these things include, due to thinness, they have deficiency in leptin, and leptin plays a role in activating GnRH. They have high levels of ghrelin, which impact on GnRH neurons. Because of the stress, they make CRH and more cortisol. So overall, they have gonadotropin deficiency and sex steroid deficiency. The increased CRH causes them to have an abnormal cortisol rhythm, and the non-thyroidal illness results in the low T3. So much more common than anorexia nervosa is something called functional hypothalamic amenorrhea. It's the second most common cause of secondary amenorrhea nowadays after PCOS. And this is amenorrhea with no obvious endocrine or organic etiology. As I said, it's the second most common cause. And you see this in women who have stressful conditions, situations such as extreme dieting, often with heavy exercise training, or those who have intense emotional events. Often there's weight loss, but not necessarily, and there is a disturbance in GnRH and thereby LH secretion. I showed you before what a normal pattern should look like. These are 3 women with a hypothalamic amenorrhea. See, they have only a very few LH secretory bursts, way less. Here's one, just a woman with 1 over 24 hours, with 3, and here's about 5. So you can see this is pulses for 12 hours here. A typical woman in the early follicular phase has 62% of the women have 6 to 9, and 12% have 3 to 6, and 25% of the women have 9 or above. And you can see that the HA patients have many fewer LH pulses in that time. So there's a disturbance in the GnRH pulse generator, somehow connected to stress, weight loss, which results in this syndrome. I wanted to mention this explanation for primary amenorrhea, congenital androgen insensitivity, which we used to call testicular feminization, which is a XY karyotype. The individuals have testes, but their androgen receptors don't work. And there are various mutations in the steroid binding or DNA binding domain. And of course, they have primary amenorrhea because they have testes and no uterus. They have a female body habitus with well-developed breasts, little or no body hair because androgens are needed for that. Their vagina ends short and ends blindly, and they have testosterone levels which are in the male range. So this just reminds you of the androgen receptor, which is a transcription factor. Its major approach to its major pathophysiology is to activate intracellular receptors and stimulate the transcription of a variety of genes. And if this doesn't work due to any of these mutations, then you could get a patient like I described. And they sometimes will look like this, with female phenotype and large breasts, but little or no pubic hair. And if you do a pelvic exam, there's no cervix. Okay, let's switch over to men. In talking about hypogonadism in males, the time of onset of the hypogonadism depends and influences the clinical picture. If you have testosterone deficiency problems, which you get in the fetus, then the male doesn't develop appropriately. You have ambiguous genitalia. If you have it in childhood or early teenage years, you'll have absent or delayed puberty. And the adult male syndrome of hypogonadism is reduced secondary sex characteristics and a decrease in libido. So, an 18-year-old man presents with a delayed puberty. He had normal childhood growth and was of average height until age 13, when most of his peers grew taller than he. He is healthy, but he doesn't shave. There's no family history of hypogonadism or anosmia. His blood pressure is normal. His span is longer, 5 centimeters, than his height. There's no gynecomastia. There's a small amount of pubic hair. The testes are each 2 centimeters long, normal about 5. The serum testosterone level was low, 50 nanograms per deciliter, and the LH level was low at LH, 1.0 milliunits per mil. Which of the following is the most likely explanation for his hypogonadism? Craniopharyngioma, Klinefelter syndrome, GnRH receptor mutation, 17-hydroxylase deficiency, 21-hydroxylase deficiency. I don't know. Good. So this is a GnRH receptor mutation. It's not Klinefelter syndrome because the gonadotropins are low. Remember I told you before, in Klinefelter syndrome, the testes are damaged from the extra chromosome, and then the gonadotropins rise. So this is hypogonadotropic hypogonadism. And understanding the endocrine abnormalities in the male is just like in the female, and that is there's feed-forward regulation of all these pituitary genes, there's activation by the testes of LH and FSH, and there's negative feedback by testosterone and estradiol. So if the testes are damaged, as in Klinefelter syndrome, the gonadotropins go up. In this case, the gonadotropins are low. Testosterone's low, you know something's going on above. You know, there's nothing to suggest craniopharyngioma, no headaches, no visual disturbances. Might you ultimately do a CT or MRI just to be sure? Sure. And 17-hydroxylase deficiency and 21-hydroxylase deficiency are forms of CAH that have a much more complicated clinical presentation than this. So when we think about hypogonadotropic hypogonadism, we divide it into congenital or acquired forms. I alluded to this before with the girls. When it's congenital, it can either occur alone, as in this case, or as part of a multigenic disorder causing hypopituitarism, often with short stature. If it's acquired, there can be pituitary tumors, prolactin, ACTH, growth hormone, etc., head trauma, infiltrative diseases like sarcoid and hemochromatosis, histiocytosis, can be a cause of infection, irradiation, and then chronic illness and nutritional problems. So congenital hypogonadotropic hypogonadism is a broad spectrum of diseases. You have someone like this who's a college student who looks very, very sexually immature with small testes and breast enlargement and no body hair at all. And then you have this guy who I saw because of osteoporosis, and he was married 3 times and never had any kids, and he too has a form of congenital hypogonadotropic hypogonadism. So if you look at the pulsatility for LH in the most severe forms with a very low testosterone and small testes, you find almost no LH pulsatility. This is normal. But in the individuals with partial problems, like 12 ml testes here, you can see an occasional burst. And now we know from the Human Genome Project and other research on genetics in this disorder that there are many, many different genes which are involved in this whole system. Some genes are involved in the movement of GnRH neurons during early fetal life, where they start in the nasal placode and have to move to the hypothalamus. And this is the well-known CAL gene, causing Kalman syndrome, familial hypogonadotropic hypogonadism, and anosmia. So because the nasal placode is where where you smell, and this genes don't work right, this whole area doesn't work correctly. The GnRH neurons remain in the nasal placode, and there's no sense of smell. But many other genes also are involved in this process. And then there are the genes which are sort of downstream of that. Once the GnRH neurons get where they belong, they have to make GnRH, and they have to activate the pituitary, and therefore GnRH receptor mutation would explain isolated hypogonadotropic hypogonadism without any of these midline defects or anosmia. And there are a lot of other genes which would do the same. Okay, a 27-year-old man presents with fatigue. He too has been otherwise healthy, and he has a normal sense of smell. He looks hypogonadal, though, with a sparse beard and soft, smooth skin. His height is 66 inches. His span is 68. His testes are larger, 4.3 by 2. And there are no other positive clinical findings. Which of the following tests is indicated at this time? Free T3, LH-FSH, TSH, IGF-1, pituitary MRI. Well, that's what I was getting at, really. What I was getting at is to remind you that people with fatigue and other symptoms like that in the setting of pituitary problems may not have just selective hypogonadotropic hypogonadism. And I guess this wasn't a good question, because I guess I would have measured the LH-FSH anyway. But this is the point, to remember, to think about the possibility of tumors in these patients. And most of them will get an MRI, and this is a big old craniopharyngioma in here. And this is a cystic component for it, and it's sort of pushing up on the diaphragm, often causing headaches and visual problems, but not necessarily. So that was the point of this, is not to jump to the conclusion that it's a congenital problem. It could be acquired, and that's what I said. He had been otherwise healthy in the past, and his testes were bigger. Maybe not the best question. Okay, a 20-year-old man was referred by his pediatrician because of small testes. He had a patent ductus arteriosus that was repaired at age 9. He graduated from high school with a B average, doing better in math than in reading comprehension. He began shaving his beard, sorry about that, at age 14, and now shaves every 2 to 3 days. He has some chest hair, but much less than his father and brother. He's 6 foot 1 inch tall. He's the tallest in the family. Dad is 5'10", mom is 5'6", and the brother is 5'9". There's no thyromegaly. He has bilateral gynecomastia. The testes are each 2.3 centimeters in length. The testosterone level is 316, the lower limit of normal, but the LH and FSH are high, 36.9 and 66.3 units per liter. Which of the following is the best next step in this man's care? Testicular biopsy, peripheral blood karyotype, pituitary MRI, SHBG and free testosterone, adrenal CT. I'm not sure. Right, so yeah. So just as in women, when you have gonadal failure and there's no obvious explanation, mumps-itis, for example, or trauma, the first thing to do is a karyotype. And this is a classic example of a patient with Klinefelter syndrome. And when you have patients with testicular failure, like I just said, some of them will have an acquired problem, and you can tell that by the history. Whereas in others, it'll be congenital, and the most common is Klinefelter syndrome, which occurs in 1 out of 500 men. So every one of you knows someone with Klinefelter syndrome. And there are other similar chromosomal disorders as well. So Klinefelter's patients could be mostly recognized by having very small testes. They also have high LH and FSH because it's primary testicular failure, and the testes rarely produce any sperm. Other findings are a little less constant. Many patients have a low testosterone level, but our patient didn't. They have less facial hair and pubic hair and breast enlargement. Sometimes you'll have an undescended testis. There seems to be an increased risk of breast cancer, and the phallus is often a bit small. But the extra X chromosome results in a large gene pool which doesn't really belong there. Many of the genes are inactivated, the so-called lion hypothesis, but many are not. So that the patients with Klinefelter syndrome have too many genes, and that causes learning disabilities, speech problems, psychiatric problems. They tend to grow with real long legs because SOX9, a gene on the X chromosome, is overexpressed, and that gene is involved in growth. They have a tendency to the metabolic syndrome with abdominal obesity, and they have a tendency to low bone mass, type 2 diabetes, and mediastinal cancers. So like I said, the best way to identify patients with Klinefelter syndrome is to examine the testes. This is the bitesticular volume. The normal testis is 20 to 25, so that the bitesticular will be out here somewhere at 50. And you can see that these patients have 4 or 6. Their testes are down here, here. And I know that all of you examine the testes when you have patients admitted to the ward. So it should be easy for you to diagnose Klinefelter syndrome in your patients. This was the paper that Klinefelter wrote in the 1940s, I think. And you can see the long legs, the tendency to breast enlargement, the sparse body hair, the small testes, but the relatively normal amount of pubic hair. This is much less severe abnormality than the severe Kalman's patients. But the testes are very tiny. But not all patients look like that. Both of these guys have Klinefelter syndrome. You can see he has a relatively long phallus here. He does have sparse body hair and breast enlargement. This guy, without examining the testes, no one would have made the diagnosis, even me. So there are many disorders causing low testosterone that affect both the testes and the GnRH pituitary unit. They don't read the textbook. And one of them is HIV-AIDS, especially in the past when the patients had a lot of weight loss. And you can get CMV and HIV affecting the testis parenchyma. So here in the bar is the percentage of the patients who have this testosterone level, and the circles are the LH and FSH. So you can see that some patients have a normal testosterone and high gonadotropins, indicating primary gonadal failure, and other patients have a very low testosterone and low gonadotropins. These are the wasted patients primarily, indicating hypogonadotropic hypogonadism, and you have all things in between. Alcoholics notoriously have damage to the testes from the alcohol, which results in the testes being small and low fertility, the low testosterone, because they often have soft, smooth skin and decreased body hair. They have decreased libido and impotence. They make too much female hormones as well, so they have breast enlargement, palmar erythema, and spiders. So you'll find in an alcoholic patient a low total testosterone often, but sometimes not, because the SHBG is very high. So the more SHBG, the higher the testosterone. So you may be confused. So you need to order a free testosterone. We'll come back to that in a bit. They have higher estrogen levels. The LH often and FSH are usually high because of the damage to the testes. And some of them have a pseudo-Cushing syndrome with increased ACTH and cortisol production. Chronic kidney disease is another example of a disorder where you see gonadal failure. This is the stages of the kidney disease. You can see the testosterone levels going down. These are in nanomolar, so just about 10 nanomolar would be the normal range. So these patients have modest decrease in testosterone levels. Sometimes they get hyperprolactinemia. The gonadotropin levels tend to rise, partly due to the medications which many of these patients receive. The low testosterone seems to be a risk factor. They have more anemia, and they have a higher death rate if they're testosterone deficient than if they're CKD patients who are not testosterone deficient. They have a slight worse, no they don't. They have more cardiovascular disease than the patients who have normal testosterone levels with CKD. Okay, now, a 42-year-old man presents with erectile dysfunction. He was married for 11 years and has 2 children. But he was divorced 2 years ago. He's otherwise healthy and takes no medicines. His libido was strong. His maternal and paternal grandmothers each had diabetes. On physical exam, he's healthy and well appearing. He's 6 foot tall. He weighs 190 pounds. BMI is 26. There's no goiter or gynecomastia. Both testes are in the normal range. His total testosterone level is reduced to 36 nanograms per deciliter. Each of the following tests is useful at this time except. I know we're not supposed to do except questions on the boards, but I have one except question. All right. Which is helpful in this guy? Lipid profile, fasting blood sugar, SHBG and free testosterone, DHEA, TSH. So which is not helpful? I'm not sure. Most people. So I think here it's really the DHEA, because this is a man who you're suspicious of having the metabolic syndrome and a low testosterone because of that. He's already been fertile, doesn't really have any headaches, he's healthy and well appearing, there's no goiter. These people, of course, have a chance of having dyslipidemia, diabetes, hypothyroidism, and as I told you, or I will tell you, one of the reasons for having a low total testosterone is a low level of SHBG, and these patients will have a normal free testosterone level. This is what's been called now adult onset or late onset hypogonadism, or andropause is another one that you'll hear. And the people with the andropause are getting younger and younger. And it's really a combination of both aging and obesity and how they affect the testicular function. The older people are going to have reduced testicular function and frailty. The younger ones are going to complain more often of erectile dysfunction, usually of the preserved libido, not a reduced libido. And that's why they'll come to your attention, because they're not too happy about the erectile dysfunction. With severe testosterone deficiency, you might have low bone mass, decreased muscle mass. Many of the patients have overweight and propensity of diabetes, and they have a low normal total testosterone like this one, and just below the normal range, and the LH and FSH are normal. They're not high, they're not low. So, sex hormone binding globulin binds about half of the testosterone in the blood in a normal man. And the more sex hormone binding globulin you have, the higher your testosterone, because you measure the testosterone by stripping off the testosterone from all these proteins. And then you measure it in an assay. So if the protein pool goes down, as in obesity, there's less total testosterone. But there may be a perfectly normal amount of the part which is called bioavailable or non-SHBG, which is a combination of the albumin-bound, the CBG-bound, and the 1 to 2%, which is free. So when you have a man with the metabolic syndrome who complains of erectile dysfunction and has a low testosterone, and you measure the total testosterone, it's probably going to be low. But if you measure the free testosterone, it's probably going to be normal. On the other hand, older men tend to have a decrease in testosterone production, so that the free testosterone goes down, and they tend to have higher levels of SHBG, which is in part due to growth hormone and other things. So here's just a group of Chinese men with or without the metabolic syndrome, and here you can see what I said before. Those with the metabolic syndrome have a lower total testosterone than the ones without the metabolic syndrome. They're also much heavier, have a higher BMI and a higher waist circumference. The LH levels are normal. They have a lower level of sex hormone binding globulin. So when you adjust to that and calculate the free testosterone in these people, it's perfectly fine. Now, all of this is a big controversy, because to define hypogonadism, you want to find a patient who has symptoms of hypogonadism, and you want to find a man who has a low testosterone. And if you have both of those, maybe the man should be treated. But it turns out that there are many, many patients who have symptoms with a normal testosterone, and there are many patients who have a low testosterone and no symptoms. Hence the controversies that you're no doubt familiar with. And this is a kind of famous study from the Massachusetts male aging study, and it's just a Venn diagram. And these are men younger than age 50. These are men older than age 50. And these are the ones who have symptoms of hypogonadism. And these are the ones who have, there's the testosterone. So you can see that there's many men who have symptoms who have a normal testosterone, total testosterone level. That's here. As the symptoms with normal testosterone is up there. If they have a low total testosterone, they may have symptoms. But the free testosterone is much more discriminatory. You can see the men without symptoms who have an abnormal free testosterone is only a very small group. So in my mind, I use the free testosterone in the setting of the symptoms before I'm willing to give out testosterone to all these men with the metabolic syndrome. Is this a controversial concept and approach? Yes. As the men get older, it's a little more difficult, because there are still many men who have symptoms who have normal free testosterone levels. But there are many patients then who have low free testosterone levels who don't have any symptoms. So, among all of the patients now being treated with testosterone, the marked increase that you read about is this group of middle-aged men, which are shown here. And they account for the majority. They're the patients in the 50s and 60s who are presenting to their doctor because they have the metabolic syndrome and ED. They're not the 75-year-old men who think, oh, I wonder if I have low testosterone and I'm going to prevent a hip fracture. Those are not the men whom you're seeing. And this is a very controversial group. So this is the only really one of the, you might have seen this, it was just recently published in the New England Journal, and it's called the T trial. And it focused on older men. The men were 65 and above. And I think, well, this is important. I think the real and more common group is the younger men, but for argument's sake, most of the other testosterone trials have been open label trials when they say Mr. So-and-so got better when I gave him testosterone. Or I was giving testosterone for X, Y, or Z reason, and I happened to also look at the other outcomes. So this trial got a lot of publicity. So what did improve is this symptom score for sexual functioning, sexual activity. And the baseline was down here at 1.4, but the range of the score, it could go up to 12. And you can see that there was an increase in the men who were randomized to receive testosterone versus the placebo. But it's still nowhere near a very normal score. So that there is an improvement in a number of sexual events and how they think about sex and all of these things with testosterone, but it's subtle. And on the other hand, other endpoints, like as the 6-minute walk, didn't really change. And this was another symptom score of vitality. That didn't change. So, I mean, one of the big controversies, if you're going to give these men testosterone, is what are the side effects? And the one which has gotten the most publicity is the potential for cardiovascular disease. So there are a bunch of studies, again, which are open label and not controlled, but have shown that the relative risk for testosterone deficiency doesn't go up. Here's the relative risk, and when it crosses 1, it's not significant. So all of these show, in essence, no increased risk for testosterone treatment. It's interesting to note that 4 out of the 5 of them were U.S. studies. On the other hand, out of these 5 studies, 4 of which are outside the U.S., there's an increased risk for heart disease. You can see that, relative risks, all of which are above the 1 and stay there. So, is there an increased risk for heart disease or not? I don't know. Some people even claim that the testosterone treatment lowers the risk. It tends to decrease the amount of visceral fat. It tends to improve the score for insulin resistance. And here's a study which dealt with survival. This is 581 men with type 2 diabetes who had testosterone levels performed, and they're followed in an open label fashion for 5 years. In some of the cases, the testosterone was treated, testosterone deficiency was treated, but in some of the cases it was left untreated. And you can see that in comparison to the normal testosterone diabetic men, the low T treated group had a similar survival, whereas those that were left untreated had a greater chance of dying. So, which is the right answer for this? I don't know. But we'll find out. The Women's Health Initiative was a study done in the 1990s of 100,000 women, which looked for cardiovascular and other outcomes in women who took oral agents, Premarin primarily, and Premarin plus Provera as a combination. And it took a very, very large, very expensive study to sort of understand to a greater extent the benefits and risks of estrogens in postmenopausal women. And it's going to take a similar, very expensive study to understand what to do with all of these men who complain with erectile dysfunction and have a low testosterone and come to you wanting to be treated. Okay, let's talk about questions and comments.
What do you say to the mid-30-year-old or 40-year-old that thinks they need testosterone?
Well, the first thing I do is do a thorough exam. I examine them top to bottom. And because there are other reasons for erectile dysfunction, neurological problems. If you don't do a very thorough neurological exam, you'll miss some. Types of vascular disease. They talk about people who ride bicycles all the time, getting pudendal vascular problems, so I ask about that. And then I, do a thorough physical and then do some endocrine tests. And if it turns out that they have, just like I presented, a man with low total testosterone, but a normal, free or bioavailable, I tell them that it's very unlikely that testosterone treatment is going to make a big impact on their erectile dysfunction. But according to FDA guidelines, I'm allowed to give them testosterone. And I know if I don't, that Dr. So-and-so next door, who isn't anywhere near as good a doctor as I am, is going to take care of them and give them the testosterone. So I offer them a 3-month trial. And then when it usually doesn't work, it does increase the libido, but that perhaps sometimes increases the level of frustration. And that's why the Viagra and Cialis are a multi-billion-dollar industry, because those drugs are effective in erectile dysfunction. Not in everybody, but they are effective. Ultimately, I have my patients do that.